Well, I'm really happy to have the opportunity to present some of my work to you guys today. IBH is an exciting place to be, and there's not a lot of opportunity to be able to share learnings from different, hospital networks and different universities. So I'm excited to share some of the work I did during my 5 years at McGill. Some of it's part of my dissertation research for my thesis, and some of it's just part of work I was involved in during my time at McGill Clinical and Health Informatics Research Group.
Yeah.
Can you hear me better?
Everybody here?
Yeah. Okay. Can't move it. Okay. So I'm going to go through about 4 different projects related to medication safety at transitions in care. So although this research was conducted at an academic teaching hospital in Montreal, I think the findings that I'm going to be presenting on are really applicable to the Trillium setting, and there's really a lot that we can learn from the work that was done over there. And since this is a really high-level look at a lot of different projects, I haven't really gone into too much detail with respect to the methods or the statistical analysis. So if you have any questions about these, please feel free to ask me. You can interrupt me, and please interrupt me at any point in the presentation that you'd like to ask questions. Like Susan mentioned, I hope this was going to be an interactive presentation. And I'm also happy to discuss any of this work after the presentation as well. So just to kind of start things off, I'm going to first kind of start discussing why we should care about medication safety issues in the transition between hospital and home here at Trillium. So reducing unplanned hospital readmissions has been a priority for most healthcare systems over the past few decades because hospital readmissions are very distressing for patients. It increases the burden on hospitals and the healthcare system. They're very costly, and they can also be an indicator of care quality. So this graph was generated using data from CIHI, and it shows that 30-day readmission rates for Trillium Health Partners, and that they've been hovering at around 8.4% for the past 5 years, which you can see it's just this bottom graph there, which is below both the provincial and national averages for 30-day readmission rates. So while some of these readmissions are unavoidable due to onsets of different health conditions a patient might have and deterioration of their health state, a proportion of the readmissions are actually preventable. So a recent study of internal medicine patients in the U.S. found that about 1 in 3 hospital readmissions was preventable, and this work is in line with work conducted by Alan Forrester and colleagues at the Ottawa Hospital, who also found that about 1 in 3 readmissions is preventable. So additionally, this U.S. study also found that half of these readmissions were actually preventable with efforts made during the index hospital admission, so the original admission that the patient had been in the hospital for in the first place. So a number of studies have found that some of the most important factors associated with preventable readmissions includes things like medication safety, discharge planning, self-management, and social support. But in this presentation, I'm mainly going to focus on the role of medication safety and its association with adverse events following a hospital stay and preventable readmissions. So medication safety issues such as incomplete drug information as well as prescribing and dispensing errors tend to be the main causes of adverse drug events following a hospital stay, which can lead to things like hospital readmissions and emergency department visits. The good news is there's actually a lot that we can do about these issues since they tend to be the result of inaccurate medication histories as well as poor documentation and communication of hospital medication changes. So one solution to begin to address these medication-related issues is something called medication reconciliation, which is a process where an accurate and comprehensive list of medications a patient is taking is created at each transition in care between hospital and home. And any additions, discontinuations, or changes to medications are supposed to be accurately documented and communicated to a patient's healthcare provider, as well as the patient themselves and any of their caregivers. So despite the importance of this process, there's actually been a lot of challenges associated with the widespread implementation of quality medication reconciliation. And this has included challenges such as obtaining an accurate community medication list, ensuring medication reconciliation is conducted for all patients, communicating drug or dose changes to community-based prescribers and physicians, as well as dispensing pharmacies. So in an effort to address some of these challenges, our research team at McGill Clinical and Health Informatics developed electronically enabled medication software, reconciliation software called WriterX. And this software consisted of 4 different components, which included the retrieval of the community medication list from pharmacy dispensing records, as well as aligning medications administered in the hospital with a patient's community medications. You can also reconcile and generate revised medication orders during hospitalization or at hospital discharge. And you can also generate the discharge prescription using this particular software with changes documented within the discharge prescription. And then you have the option to fax the discharge prescription to a patient's community pharmacy or their physician. So this is a main view of the software. It's really small. Sorry about that. So the first pane, just right here, this shows the aligned and validated community drug list. So this is a list of medications that were pulled from the patient's community dispensing records. And the pane in the middle, can you see my cursor? Yeah, right there. Those are all the medications that were administered to the patient in hospital, aligned next to the community medications. And then you can see here the discharge module, which is used to create the discharge prescription for the patient, where each of the medications from these 2 lists is acted on. So a physician can either choose to continue, stop, change the dose, or prescribe a new medication at discharge. And this is what this pane allows you to do here. I lost my cursor. There we go. And this is what the discharge prescription looks like that's generated from the software. So as you can see here, it's broken up according to the type of change that was made to the medication. So we have stopped medications here, modified medications, continued meds, and new meds. And then you have the prescriber information in the community, as well as the pharmacy. So just to give an example of a modified medication, so here the in-hospital physician stopped the patient's metoprolol, and they just changed the dose of it. They changed it from 100 milligrams per day to 25 milligrams twice per day. So that ends up being, I think, 50 milligrams per day. So just to give an example of the clear communication of the hospital medication changes and the generation of the discharge prescription using this particular software. So does anybody have any questions about the software, what it's used for, why we might want to use software like this in order to conduct medication reconciliation? No? Okay. We'll move on then.
I had a question.
Yeah.
So
Yeah.
with the community medications, what are the data sources for those inputs?
Yeah, it's a really good question. So we actually were able to access the provincial dispensing records for each patient. We had to have consent in order to do that, of course, but once we got consent from each patient, we were able to send this information to the RAMQ, essentially the Quebec Provincial Administrative Healthcare Database, and then they sent us all of the dispensing records for that particular patient. Quebec also, so that was for the purposes of this software, that we could pull all that information in and then pre-populate the community drug list using that information. But in Quebec, we have an electronic health record called the DSQ. So any healthcare provider with log information can go in and access similar information. They can access all of the community dispensing data for their patient. They can only view it though. They can't actually take that data and do anything with it. So yeah, we were lucky to have access to that data. Yeah. Any other questions? Yeah.
Who uses the software?
So at the time of the study, the residents used it, the medical residents, attending physicians used it, as well as if there was a pharmacist working on the one of the study units, they could use it as well.
It's in the hospital.
It's in the hospital, yeah, exactly, yeah. Yeah. Anything else? Yeah, it was on the units.
Does it go back to the family physicians?
Pardon me?
Does it go back to this information get back to the family physicians?
Yeah, so this discharge prescription that was generated through the software, it could actually be, it was faxed to the patient's community pharmacist as well as their community physician. So the intention was to have all this information communicated to their community-based care team. Yeah.
So who would be the most responsible physician who would send this off? Who's got the bottom line sign off on it?
It's the attending.
Oh,
The attending physician is the one who signs the discharge prescription, but they might not have been the person that was most involved in the care of the patient to begin with. So yes, they have the final authority on the sign off, but it could have been the resident that had done all of the prescribing for that particular patient. We did record the resident's license number, I think, onto this, so there was a way to link the patient's discharge prescription to the resident. But in the end, it is ultimately it's the responsibility of the attending physician. Yeah.
Sorry, just for the context for the study,
Mhm.
was this set up as a kind of a pilot, or was the idea that it was to be rolled out, or was just a kind of a one-off given the prior work that I know you guys had were doing there?
So this was we ended up, and I'll get into that. We ended up doing like a full RCT. We piloted it first, and I'll get into the RCT in the next study. Or in the next slide, but yeah, this was a multi-year big RCT that we conducted. So yeah, it started off as a pilot, but definitely grew from there. So it's a good segue into, unless anybody else has any other questions, I'm going to get into the trial for this. No? Okay. So, like I said, we ended up conducting a cluster randomized trial at the McGill University Health Center in order to determine whether electronically enabled medication reconciliation using this WriterX software reduced the incidence of adverse drug events, emergency department visits, and hospital readmissions compared to usual care. So usual care kind of did depend on the unit that we were rolling the intervention out on. Internal medicine units at the MUHC actually already had a pretty good MedRec system in place. It was paper-based. It's paper-based PDF form, but surgical units really didn't have any way of doing MedRec. So usual care was dependent on the unit that we were rolling the software out in. So we actually just published the results of this trial in JAMA Open, I think 2 months ago now. So if you really want to go take a look at all the details, it's there. You can access it online. So this is a flowchart of the study patients that were included in the RCT. So we started off with about 8,000 patients who were admitted to cardiac and thoracic surgery units as well as internal medicine units between October 2014 and November 2016. We excluded those who didn't have public provincial drug coverage through the province, those who weren't discharged from a study unit, and those who, of course, didn't provide consent to be part of the study. So we ended up randomizing about 1,800 people to the control group and 1,600 people to the intervention group. So I'm talking about patients here, but this was a cluster randomized trial, so we actually randomized units to receive the intervention or not, because it just wasn't feasible to randomize individual patients to the software or not. Okay, so in terms of the types of patients that we included in our study, mean age was 70. About 53% were discharged from internal medicine, 26% were from cardiac surgery, and 22% were from thoracic surgery. 58% of patients were male, just because of the inclusion of the cardiac surgery unit, which was predominantly males. In terms of pre-admission healthcare service utilization, the mean number of ED visits was 3, and 49% of patients had at least one prior hospitalization. Patients had an average of 5 chronic conditions, were using about 6 medications at admission, and were prescribed about 8 medications at discharge. So this was a relatively older and sicker patient population. So moving along to the main results of the study. So when we compared intervention and control patients, we found that there were no differences in the risk of adverse drug events, emergency department visits, or hospital readmissions between the two groups. We did find, however, that medication discrepancies were lower among intervention patients compared to control patients. So this included lower rates of things like therapy duplications, omissions, and dose errors. We also found that increasing numbers of medication changes and newly prescribed medications were some of the most significant risk factors for the occurrence of adverse drug events post-discharge. So as you can imagine, these results were a little bit surprising to us, since medication reconciliation is really resource intensive, and it's actually required for hospital accreditation. So we'd expect that quality MedRec would lead to improvements in health outcomes for patients, or we would hope that they would. So our team really did try and sit down and think about, what could be driving the results that we were observing in this study. So first of all, it's possible that any medication discrepancies with the potential to cause patients harm post-discharge were actually corrected by the community pharmacy or their community physician post-discharge before they caused any issues. And since we found that the greatest risk of adverse drug events seemed to occur when patients had a greater number of medication changes or new medications that were added, we hypothesized that close follow-up for these patients who are using new medications might be something important to consider moving forward, as this could be driving rehospitalizations. So any questions about the results of the study? Yeah.
Most of your patients that were discharged, like most of our patients, have multiple chronic illnesses.
Mhm.
So for the ED readmission rate, were you looking at 7 days or 30 days?
We looked at 30 days and 90 days, and we actually ended up looking at 3-month readmissions too, because depending on the timing, there's different reasons for each of the readmissions at those different timelines.
Because I would guess the further out you go, the less the effect of the medication reconciliation will have.
Yeah,
Because
absolutely.
of the nature of the chronic diseases, that's what we found.
Yeah, absolutely. Like, the reality is these are very sick patients. They've got, 8 different chronic conditions. They're using 8 medications. So there's only, maybe so much that MedRec can do in order to improve health outcomes for these patients. And there's a lot that can happen in the meantime.
There may be an association also between how many medications get changed in hospital and how sick they are.
Mm-hmm.
So it may be a bit of a confounding variable.
We actually found that internal medicine patients tended to be the sickest in terms of number of medications and number of chronic conditions. And those who were coming in on a lot of medications, actually, they weren't changing their medications too much. The people who were having the greatest number of changes were actually the cardiac surgery patients, because I think they were having, some sort of new cardiac event, and they had a whole onslaught of new medications prescribed to them. So we actually, yes, on some level, some of the patients who were sicker would have had more changes, but we actually found that, it was the cardiac surgery patients who we were seeing had the greatest number of changes and new medications being added.
Because they're less sick.
Yeah, compared to the internal med patients, yeah, absolutely. Any other questions? No? Okay. So another possible explanation that could help explain some of the results we observed is that patients aren't actually following the changes that are made to their home medications during hospitalization after they're discharged. So 2 studies that were conducted in Ontario reported that about 25% of patients don't actually fill their newly prescribed medications in the community after they're discharged from hospital. And no studies really evaluated the association between not following the changes made to patients' medications and adverse drug events after discharge. So we weren't sure whether or not this could be potentially driving medication-related adverse events. So we also hypothesized that inappropriate prescribing at discharge could be leading to adverse drug events following hospitalization. So only a few studies have been published to date evaluating the prevalence of inappropriate prescribing at discharge, and these studies have really reported conflicting results. Some studies have reported an increase in the prevalence of potentially inappropriate medications at admission or at discharge. Some studies have reported a decrease. And no study has actually evaluated the association between inappropriate prescribing at hospital discharge and health outcomes. So I decided to explore the issue of adherence to the discharge prescription, as well as inappropriate prescribing as potential factors associated with adverse events in the transition between hospital and home for my doctoral dissertation research. So I ended up linking all of the information we had on almost 3,500 of the RightRx trial patients, including their in-hospital diagnoses and procedures, as well as all of the medications that were administered to them in hospital, the results of their lab tests, and their discharge prescription information with administrative health data from the RAMQ. So this is similar to data we would get from ICES here in Ontario. So this included medical services and prescription claims information for the year prior to and the year following discharge for all of the trial patients. And we also ended up conducting a telephone interview with patients in the 30 days post-discharge where we were able to collect information to determine whether an individual had experienced an adverse drug event. Any questions about the data that was used? It was just the data from the original trial, and we were reusing it in a secondary analysis for these additional studies. Okay, so the objective of the first study that was part of my thesis was to estimate the incidence of and characteristics that were associated with non-adherence to hospital medication changes in the 30 days after hospitalization. So non-adherence to medication changes post-discharge was defined as new medications which were not filled at a community pharmacy post-discharge, dose changes which were filled at the incorrect dose, and discontinued medications that were filled. So this study found that overall, about 1 in 4 hospital medication changes was not followed in the 30 days after discharge. So this included about 27% of newly prescribed medications that weren't filled at a community pharmacy by the patient, 12% of discontinued medications that were filled, and about 30% of dose changes that were filled at the incorrect dose. Any questions about this? Does that surprise you guys? Do you think it was higher or lower than what you would have expected? Or if that's what you would have expected?
It's lower than what I expected.
Is lower than what you would expect? Okay.
The second two surprised me.
Yeah.
Yeah. We found for these ones, these tended to be the benzodiazepines that were being discontinued in hospital, and then patients were still filling them post-discharge because they're used to taking them and they're habituated to them. So that was, we published a study on this, and we go into a ton of detail in terms of the medication classes that were specific to each type of change that wasn't followed. So if you want to see more details, you can come talk to me later, and we've published a study. I can send you the file. But yeah, it was some pretty interesting findings. Yeah.
Maybe I'm being naive, but how do you get dosage changes filled at the incorrect dose?
Yeah, that's a really good question. So what I was able to no, you're right. So what I was able to calculate was the daily dose of a prescribed medication at discharge based on my discharge prescription information. So if there was, the discharge prescription said take 50 milligrams of bisoprolol per day, I'd have that information at discharge, and then I had their community dispensing record, and I had the strength and the quantity of the medication that was dispensed, as well as the ingredient. So I could calculate from that dispensing data the daily dose that was dispensed. So what I ended up doing was comparing the two. And
So the dispensing pharmacy are just getting the dose wrong?
so a lot of the time the change wasn't communicated properly. Either it was, to the pharmacist. So either it was it was unclear in the discharge prescription what the intended dose was, or it wasn't clear that a change had been made. A patient could have been taking 50 milligrams prior to admission of bisoprolol. It might have been reduced to 25 milligrams at discharge, but that change isn't communicated properly, and it's just redispensed at the same dose as it was prior to admission.
And this is not necessarily using your new format. These are people who would have been discharged from the hospital without that MedRec thing.
It would have been with or without.
With or without. Okay,
Yeah,
that
so
explains.
chance, we did do a few analyses where we stratified patients according to whether they were part of the intervention or control group to see if any of these things were different. We didn't actually see that many differences between the two groups. It's a little bit discouraging, but you would have thought that all of that, communication it was a little bit lower. The dose changes, the discrepancies for the dose changes and discontinuations were a little bit lower in the intervention group, but not as, it wasn't reduced to the extent that we would have expected it to be. But yeah, good question.
And which of these would be called medical errors? Any?
Depends who you
Depends.
ask.
Yeah.
It depends who you ask, because some of these could have been errors at discharge, and then they were rectified in the community afterwards at the pharmacy. It could be. I read some of the interview data post-discharge, and patients were saying things like, I'm allergic to this medication. I told the physicians I was allergic to this medication. They still prescribed it to me at discharge. So them not filling that new medication could potentially be a good thing if they're allergic to it, or as we'll see in the next study, it's potentially inappropriate. But then if it is a discrepancy, if it should have been dispensed and it wasn't. So it depends on what perspective you're looking at all of this, if it's an error or not. You really have to do a deep dive into what's going on. So yeah, some of them are errors, and some of them are probably for the best that you're not following what's on the discharge prescription. But you have to choose kind of a perspective on the analysis. It's either you follow the discharge prescription or you don't, and that's kind of what we looked at for this particular study. Is we're intending that it should be followed, or we're thinking it should be. Yeah.
I was gonna say, I think another non-adherence would be medications that were filled but not taken.
Mm-hmm.
And I was wondering if you got tapped into that in some of the follow-ups, telephone surveys, or
Yeah.
I'm sure everybody lies and said they
Yeah.
took
Yeah.
everybody who prescribed it.
Yeah. So we did ask as part of the telephone survey, are there any medications that you have filled that you're not taking? And yeah, it's another like 10%, I think, on top of the non-adherence that we were already looking at. So there's no way for us to, other than observing the patient to see whether they're taking their meds, whether they're taking them or not. But we know on top of patients not going to the pharmacy and filling their meds, they might be filling them, but they might not be taking them. So yeah, that's a really good point. Any other questions or comments? Okay. So in terms of some of the most important variables that were associated with increasing non-adherence to medication changes, I found that medications that weren't actually administered to the patient in hospital were much less likely to be followed compared to medications that were administered to the patient in hospital, so they were familiar with them. At the patient level, I found that those who were discharged to long-term care compared to those who were discharged to the community, and those who were not dispensed any medications prior to hospitalization were a lot less likely to adhere to their medication changes. And also found that patients who had to pay more out of pocket for their medications were less likely to fill new medications compared to those who had to pay less. So the results of this study suggest that poor communication of hospital medication changes to patients and caregivers may be occurring during the discharge process, that patient education may be important to consider moving forward, and that reducing out-of-pocket costs for medications for patients could be an important health policy to consider moving forward to address this issue. So on to the objective of the next study, which was to actually estimate the association between non-adherence to medication changes made at discharge and the risk of readmissions, ED visits, and death in 30 days. So when non-adherence to medication changes was measured over the entire follow-up period at the patient level, I found that about 6% of patients were not adherent to any of their medication changes. 38% of patients were adherent to some of their changes, and 56% of patients were adherent to all of their medication changes. So in terms of the incidence of the composite endpoint in 30 days post-discharge, I found that 32% of patients were readmitted to hospital, visited the ED, or died, and the majority of these events were ED visits. So when I evaluated the association between non-adherence to medication changes and adverse events in 30 days, I found that patients who were not adherent to any of their medication changes had a 35% increased risk of experiencing a rehospitalization, ED visit, or death, compared to those who were adherent to all of their medication changes in the post-discharge period. So the results of this study do make a stronger case for conducting future research aimed at better understanding the mechanisms that are driving this issue from the first study, and to develop and implement policy and interventions to help address these issues. So any questions about the first two studies related to non-adherence and their impact on adverse events post-discharge?
I just might ask what kind of future research, like are you thinking more sort of qualitative type research to understand the behavioral incentives, motivations,
Yeah.
barriers, those
Yeah,
kinds of things?
exactly. So I'll get to this a little bit at the end. We developed a little medication management app called Smart About Meds, which is based on kind of the interview data that we conduct with patients to understand why they're not filling their meds. So we kind of developed this little app to help target some of those issues. So we're thinking more interventions related to improving this issue or reducing it in any way we can, yeah. And more qualitative data, I think, too, to better understand it, because we just have the tip of the iceberg in terms of why this is an issue. Some health policy related to the cost of medications, I think, is related to National Pharmacare, which, if that gets rolled out, I think that'll help to address some of the cost-related barriers to patients filling their medications. Yeah. Okay. So I'm going to move on to the last study. So the objective of the last study was to estimate the incidence of potentially inappropriate medications prescribed at hospital discharge and their impact on readmissions, emergency department visits, and death, as well as drug-related adverse events in the 30 days post-discharge. So potentially inappropriate medications, or PIMS, are prescribed at discharge and were measured using the Beers Stop and Choosing Wisely criteria. And these are medications that are defined as those that have a greater risk of harm than clinical benefit in those who are 65 years of age or older, and they could potentially be replaced by a safer alternative treatment. So in this study, I distinguished between potentially inappropriate medications prescribed at discharge that were continued from the community, as well as those that were newly prescribed during the hospitalization and then prescribed at discharge. Does that make sense to everybody, what potentially inappropriate medications are, how they're measured, just based on what was in the discharge prescription, based on those criteria? Yeah. Okay, so when I looked at the incidence of PIM prescribing at discharge, I found that 2 in 3 patients were prescribed at least one potentially inappropriate medication, where 49% had a PIM that was continued from the community, and 31% had a PIM that was newly prescribed at discharge. So when I looked at the incidence of the primary and secondary outcomes for this study, I found that 9% of patients experienced a drug-related adverse event post-discharge, and 35% of patients were readmitted to hospital, visited the ED, or died. So some of the most common newly prescribed PIMS included things like benzodiazepines in patients without anxiety or epilepsy, as well as proton pump inhibitors in patients without GI hemorrhage or peptic ulcer. There's also things like COX-2 inhibitors, opioids, and atypical antipsychotics that popped up on this list. So when I evaluated the association between PIMS prescribed at discharge and the risk of adverse events post-discharge, I found that both PIMS that were continuing from the community and new PIMS were associated with an increased risk of both the composite endpoint as well as drug-related adverse events post-discharge, but the strength of this association was consistently highest for new, potentially inappropriate medications. So, for example, I found that each additional newly prescribed PIM was associated with a 21% increased risk of drug-related adverse events post-discharge. So there may be several important underlying issues that are contributing to the high prevalence of PIM prescribing. So this may include physician factors such as lack of necessary decision support to identify and communicate PIMS, as well as poor oversight over prescribing for trainees. Health system factors can also potentially be an issue here, including fragmented and difficult to access patient records, as well as standing order sets in hospital for the prescription of benzodiazepines and proton pump inhibitors. So given that PIMS prescribed at discharge may be an important factor contributing to avoidable adverse events at the transition between hospital and home, the study really does emphasize the importance of further investigating and addressing these factors that could potentially be contributing to this important issue. So any questions about that study, potentially inappropriate prescribing at discharge? Yeah. Okay. So overall, I think the results of the research I've presented so far emphasize the need for developing medication-related interventions which have the potential to improve health outcomes for patients in the transition between hospital and home. So in an effort to begin to address some of these issues, our team recently developed a patient and caregiver-centered mobile application to enhance medication management for patients post-discharge, and it's called Smart About Meds, or SAM, and we're currently piloting it at 3 hospitals in Montreal. So really briefly, some of the main features of this application include an active medication list, highlighting in-hospital medication changes for patients, drug alerts for patients if they haven't filled a new medication or they have filled a discontinued medication. We've given them information for each prescribed medication and its possible side effects, as well as a messaging feature which allows the patient or caregiver to communicate with the in-hospital pharmacist if they have any questions or concerns about their medications. So this is just a really quick little view here of the main page for the patients. So you have just the medication here, the name it was prescribed at, and then if the patient has it dispensed in the community pharmacy, there's a little check mark that shows up there. It has the dosage information. The patient can click on the little information button here, so it gives, information on side effects and how the patient's supposed to use the medication. If they click on this little message button here, it gives them the option to message with the hospital pharmacist as well. And we just implemented a new feature. It hasn't showed up in here in these screenshots, but about medication side effects. So when you click on the information button, it'll actually pop up the, I think, 10 most prevalent side effects associated with each of their prescribed medications. Yeah.
Do you find that mostly the caregivers are using this rather than the patients through the patient's age, or?
So we just started piloting it. We only have like 15 people in the study. So I think that it's mostly caregivers though, and it depends on the unit, again, and the age of the patient. So I think for the sicker, older patients, it will be predominantly the caregiver that's using it. That being said, there are a few older patients that are using this application as well. So we're gonna have to wait and see. It'll be interesting to see once we've enrolled everybody in the study what kind of the cutoff is in terms of who's using the app, whether it's the patient or the caregiver.
I really like that picture of what the pill looks like.
Yeah, it's cool. Yeah, it's really cool. We work with this company. It's called Vigilance Santé, and they provide a lot of information and data to us that we pay for. They don't just provide it to us. So this includes all of the pill images that you can create apps, and they actually are providing us with the information on the medication side effects. So it's a little engine that the company has where we feed them the information in the discharge prescription. It spits out the top 10, I think, most common side effects, and then we can display it in the app. So it's commercial decision support software, essentially, like Pharmaprix or Shoppers Drug Mart uses it, and a lot of different healthcare organizations use this data from Vigilance. So yeah, it's great. Yeah.
And what approach did you guys use to developing and designing the app for the user?
Excuse me. Approach as in whether it was like patient-centered or we just kind of
Yeah.
went there.
Yeah.
So, it started off with, I know there's supposed to be, a very clear process, but we kind of just, the lead of our team, Dr. Chamblin, she kind of had an idea and a vision for what she kind of had in mind for this app, and so she kind of just drew it out on a piece of paper and we went from there, to be honest.
Okay.
That's how we did it, but we've, in the meantime, we've designed it, we've showed it to patients and caregivers, gotten their feedback on it, and said, we have a usability assessment that's been built into the piloting of this. So we are, it did start off with Robin's idea in the first place, but we've definitely been getting input from usability experts along the way and software developers and everything. So yeah, it's definitely been a work in progress. It's changed a lot. These are even old screenshots of the app. It looks a little bit different now, and just improving it as we go. So it's been exciting. It's been a fun project.
My colleagues were just pointing out that there's a patient review column there.
Yeah.
Which is
You know what?
interesting, so I'm curious about change,
So-
I need a grape one instead of a, But I just think that, I'm curious about who's monitoring that and if anybody is using that information for.
So I specifically didn't talk about it because I don't like that feature. I've been against it since the beginning, but my opinion's been vetoed because it's kind of like, what does your opinion on the medication mean? Do you like the color? Does it cost too much? Does it, give you a stomach ache? So I never liked it because I thought it was very ambiguous as to what exactly does it really mean.
Yeah.
Agree 100%, but sometimes you just have to,
Interesting source of data. But is anybody actually using it?
You know what? I think one person's used it so far in the pilot, and it's, and other patients can see that information too. It was kind of the thought behind it was like it was a TripAdvisor sort of thing, give it like a 4 stars sort of. But I just always thought that it wasn't clear as to exactly what the rating is. Yeah. So.
Frequent prescribed cannabis.
And a lot of the piloting we've done with the patients and the usability, they didn't understand what it was for. So
Through that process, you then remove it?
well, yeah.
Okay, so I'm not gonna.
You would think so. Like I said, I've got my opinions on it, and
Postdoc vote. Yes. It needs to
Yeah.
count for 5.
well, it was only the PhD vote then, the student vote, so it didn't count for much of anything. So anyways, I hear what you're saying. I agree with you, and hopefully the next time I'll show you a screenshot of this, it'll be gone.
And it actually may help you predict which medications they're going to refuse to stop taking.
Exactly.
Yeah,
Exactly.
yeah, it could be.
Like the benzodiazepines will score.
My supervisor would like you. Yeah, no, you're right. There could be some benefit to looking at some of these comments. I think that other patients potentially shouldn't be able to see it though, because if non-adherence is already kind of an issue, it might not be great to give people yet another reason not to take their prescribed medications. Yeah.
Well,
Yeah.
the side effects vary, right?
Yeah.
So-
Yeah. Exactly.
So
Yeah.
interesting.
So this has been this is probably my favorite part of my PhD, to be honest. It was really fun developing this, and it was nice that the work that I did conduct in terms of my studies helped to inform what we were actually going to target in this application. So it was really nice to see the work kind of progress and go somewhere after that. So yeah. If anyone's interested, I can show them a demo at some point afterwards. Just come and talk to me, and I can pull it up for you. Okay, so now I kind of would like to, how much time do I have left? A little bit. We've been discussing like intermittently throughout, so I have a little bit of time still.
Maybe 5 minutes.
Yeah, absolutely. I can wrap it up in 5 minutes. So what I'd really like to focus on now is kind of switch gears and talk about what could this mean for the delivery of care at Trillium Health Partners. So I feel like the results of this research can help to inform how to create a better learning healthcare system at Trillium through the development, implementation, and testing of interventions to improve the quality of care transitions between hospital and home. So while I think that medications are obviously a really important component of quality care transitions, I think that a really more well-rounded approach that focuses on the entire transition process is really likely required moving forward to improve health outcomes for patients overall. So in an effort to develop the learning healthcare system, like one of the questions you have to ask is, well, what hasn't really worked in the past related to improving care transitions? And when it comes to care transition interventions, the literature has been pretty clear that single component interventions have not really led to any sort of meaningful improvements in terms of clinical outcomes or patient-centered outcomes over the past few years. So what could work in the future in order to improve care transitions? Well, there's been some evidence to suggest that multiple concurrent interventions might be more effective and should likely include things like improved collaborations between hospital and community care teams, enhanced patient education and empowerment, as well as transitional care managers. So we also need to consider, who would be best to target these interventions towards. So the patients who are likely to benefit the most are those who are at high risk of being readmitted to hospital. So this could include people who are taking high-risk medications, those who have many different chronic conditions, as well as those who have particular high-risk chronic conditions such as COPD or heart failure. So it's also really important to build any sort of transitional care interventions around what's important to patients, families, and caregivers, as well as to consider their own experiences. So some work's been done at the national level by CIHI through their patient experience in hospital survey, which reports that about 62% of patients say that their hospital experience overall was good, and that about 54% of patients felt that their medications were always well explained to them during their hospital stay. So this suggests there's definitely room for some improvement here. The results of a survey conducted by Health Quality Ontario identified some of the top issues for Ontarians in the transition between hospital and home, which included things like not having home care in place before they arrive back home from the hospital, not being involved in discharge planning, and not having the contact information for people to call if there was an issue following their hospital stay. Excuse me. So this study was conducted by Susan Okranik and her colleagues over at University Health Network, and they evaluated patient and caregiver perspectives on what influences the understanding of and adherence to hospital discharge instructions. So key perspectives from this study included patients needing to know, what to expect following discharge, and they reported feeling rushed and wanting to know what signs and symptoms they should be looking for when they go home, in addition to adequate home care and support. And families and caregivers expressed the desire to be present at discharge, as well as the importance of potentially having a translator on the care team. So this is why I think that patient and caregiver engagement and co-design is key to the process of improving transitions in care, and we certainly have experts here which can help to inform this process moving forward. I'm pretty much done. I just want to speak really, really quickly about with respect to moving forward with this transitions in care work over the next 2 years. I've had the opportunity to meet with people from both Trillium and IBH, including Alison Quigley, Sharon Gibbons, as well as Carrie Kaluski and Terrence Tang, to kind of begin to understand, the current state of transitions in care at Trillium, some priority areas I can potentially focus on related to quality, as well as practical and actionable items that we can actually focus on. So I'm really looking forward to working with everybody over the next few years on this particular project. So I'd like to just acknowledge quickly the funding I received during my doctoral studies, as well as the funding for the Writer X and SAM studies. And my thesis committee, including my primary supervisor, Dr. Robin Tamblin, the SAM study team, the Writer X study team, as well as Walter for bringing me over here in the first place, and as well as Allison Quigley, who's my supervisor at Trillium. So, thank you very much for listening, and I'm happy to answer questions.